First of all, I'd like to thank you for the introduction, and I'm really honored to be here. I really admire what you do in Hong Kong, and it's a pleasure to collaborate with Hong Kong friends and colleagues, and to be here to discuss the role of a double or triple therapy in metastatic hormone-sensitive prostate cancer. And when we look back at the disease history of prostate cancer patients, these patients were patients typically managed with some form of local therapies at the time of local disease onset. Then they received ADT, they progressed, and at the time of progression to metastatic castration-resistant state, they got some other forms of therapies. Luckily, nowadays, the paradigm has changed, and we are talking about completely different treatment combinations. You can see that ADT does not represent the standard of care anymore for the management of newly metastatic or recurrent prostate cancer patients with metastases. And you can see that novel treatment options emerged, such as docetaxel. So we are talking about ADT plus docetaxel, or plus novel ARTAs, which are basically enzalutamide, apalutamide, darolutamide, or even abiraterone, even if it works in a little different way. And these therapies have been proved to improve, actually, prostate cancer survival, overall survival, in randomized controlled trials. And it's quite disappointing to see that when we look at US data, population-based real-world data, the vast majority of urologists is still using ADT only when treating metastatic hormone-sensitive prostate cancer. So these patients are still nowadays somehow under-treated even at Western countries. So we're talking again about the US data. And these are the basis. This is the combination of ADT plus docetaxel, and we will discuss in a minute why this does not represent the standard of care anymore. And we have been discussing with Professor Shariat about trials where actually patients were randomized to ADT plus ARTIS compared to the standard of care. And in that trials, the standard of care was represented by ADT alone. So you can see how fastly the paradigm has changed over the last few years. Well, docetaxel is superior to ADT alone, and you can see that it provides approximately 20 to 25% of survival advantage at a median follow-up of more than 5 years. We are talking about metastatic hormone-sensitive patients, but this is an heterogeneous population. We can further stratify our patient based on several disease features. First of all, we have risk classes, and we can divide patients in high or low volume according to the number of metastases. And this is the so-called Chartid classification. We can also divide patients according to their risk, and the risk is based again on the number of metastases and also on ISUP grade. And this is the so-called latitude risk groups, high versus low risks. What emerged in recent years is that also the timing of the onset of the metastasis plays a major role. We have patients with a synchronous metastasis, and we have the ones who had a prior local therapy, and actually patients who recurred to a metastatic disease stage after a local therapy are the ones who harbor a better prognosis, as you can see in this data. So this is to explain why, when we look at these trials, we should also look at the efficacy according to tumor burden and according to the timing of the onset of the metastasis. When we look at the Chartid trial, and the Chartid is a trial which randomized the patients to ADT versus ADT plus docetaxel, well, the major effect for the combination therapy, docetaxel plus ADT, was in patients with high volume disease. While when patients were stratified according to disease volume, for low volume disease, no benefit was observed. Docetaxel is associated with a substantial risk of side effects, is not well tolerated, and not all our patients can actually receive docetaxel. And this is why the role of novel combination therapies emerged. And here you can see the trials, currently available trials, aimed at comparing the role of double treatment, ADT plus RC, and here we are talking about enzalutamide, apalutamide, and we have also trials on darolutamide. And these trials compared ADT plus RC versus ADT alone mainly, even if some patients, and you can see, for example, in the ENZAMET trial, up to 45% of the patients received the prior docetaxel therapy. So we are not really comparing ADT alone, but it's ADT in the 45% of the cases, ADT plus docetaxel versus ADT plus enzalutamide here. What is interesting is that the hazard ratio, so the survival benefit, was consistent across all 3 trials, regardless of the type of therapy you use, and you can see that the hazard ratio is virtually the same, 0.67. And we're talking about trials with relatively long follow-up, up to 5 years in some cases, and in the ENZAMET trial again, and we will go back to this, up to 40% of the patients received the prior local therapy. So we're talking about a relatively high number also of metacronous patients. What can we say about the comparison of these therapies? We have seen we have different molecules, and well, we should rely on network meta-analysis. We do not have direct randomized level 1 data comparing different double therapies, and unfortunately, we do not have a direct comparison of a double therapy with a novel RC and a double therapy with docetaxel. But still, we can see that some molecules might perform better than others, even if we are talking about low evidence or better, high evidence, which is used in a network meta-analysis, and at the end, this cannot be compared to level 1 data. But still, we have some molecules, such as enzalutamide, who are performing better, particularly in the low volume setting, when we are talking about double therapy. Things got more complicated recently, and we're talking about 1 year ago, where novel trials tested the role of the so-called triplet therapy, which is based on ADT, which is the backbone therapy. All these trials always administer ADT. ADT is there to stay, but we have to add something. We discussed about adding docetaxel, and the next idea was to add an ARSA, which is darolutamide or abiraterone acetate, to ADT plus docetaxel. So these patients are actually receiving the triple therapy, and as Professor Chagat recently told us, in some cases they even receive radiotherapy. So, and we are talking about the PEACE-1 trial, where some patients actually received ADT, docetaxel, abiraterone, and radiotherapy. So these are patients where we try to maximize our ability to treat the disease and to maximize the chance to get a long-term oncological control. These are the trial designs, and when we look at the results, we can see that two main differences should be noted among the 2 trials. In the ARASENS trial, we are talking about 86% of synchronous disease, but we still have a small proportion of men who are metachronous. When we talk about the PEACE-1, all of them were de novo metastatic, so all synchronous disease. We do not have metachronous prostate cancer. So we can say that when we try to apply the results of these trials, supporting ADT plus docetaxel plus an RC, we are mainly talking about patients with a de novo synchronous metastatic hormone-sensitive prostate cancer. It's difficult to translate these results to the metachronous setting, but still we have a survival advantage, and this is confirmed in meta-analysis. The main benefit appears to be in men with high risk or high volume prostate cancer. We might have a benefit in the low risk scenario according to latitude, and network meta-analysis were unable to prove a significant benefit due also to the low number of patients in the low risk setting, low volume setting, sorry. In the low risk there was a benefit. And when we compare these results to ADT plus RC alone, we should remember that no available trials and no level 1 evidence is there to tell us whether ADT plus docetaxel is equivalent or is better compared to ADT plus an RC without docetaxel. So we should rely on a network meta-analysis. This is a very nice study done by a colleague of mine who was able to combine data from different randomized trials, and you can see that ADT plus docetaxel plus an RC was able to provide a better survival compared to ADT plus docetaxel alone, but the survival benefit of ADT plus an RC was similar compared to the triple therapy. So double therapy with an RC might be equivalent according to these non-randomized findings, and meta-analysis might be equivalent to a triple therapy. But still, they do better compared to ADT plus docetaxel alone. And the issue is also about timing of metastasis. And as I was saying, when we talk about the triple therapy, we should remember that this mainly applies to synchronous de novo metastatic disease. So it's hard to translate, due to the low number of patients with metachronous disease, it's hard to translate these results to the recurrent setting or to the metachronous setting. And when we look at the double therapy trials, we should also remember that many of the patients included in the ENZAMET trial actually had a metachronous disease. 40% of them received prior local therapies, and many of them also received concomitant docetaxel. And when we look at the hazard ratio, it's very similar compared to PIS1 or Arazens. So other forms of ADT plus, for example, enzalutamide can work in the same way compared to ADT plus darolutamide in the setting of de novo disease. And when we talk about metachronous disease, the triple therapy probably cannot be used based on available data. We should also acknowledge that safety represents an issue. And when we look at the tolerability and the side effects of these therapies, we should remember that the use of chemotherapy and docetaxel is the driver for the risk of adverse events. And mainly patients with, you can see here another very nicely done meta-analysis by the group of Professor Sheriat, where data from randomized trials were combined, and we can see that the use of docetaxel was actually, regardless of the type of ADT you use, darolutamide or abiraterone, was the driver for a higher risk of severe adverse events. And this also has an impact on quality of life. And when we use docetaxel, we can see an immediate deterioration of quality of life in up to 1 out of 4 or 3 of our patients. So this is to be accounted for when we are selecting the best therapy and when we are selecting ADT plus an RC or the so-called triple therapy. And this is my final slide. These are my messages. Please consider that ADT plus docetaxel alone does not represent the standard of care anymore when we talk about metastatic hormone-sensitive prostate cancer. And when we look at the latest version of the EAU guidelines, it is not there anymore. When we should treat our metastatic hormone-sensitive patients, ADT plus RC is the standard of care, and when the patient is fit for docetaxel and he accepts the risk of toxicity associated with docetaxel, the triple therapy, particularly in the de novo synchronous metastatic hormone-sensitive setting, will play a major role and improve survival. Thank you very much for your attention.